your presentation.
Okay, ma'am. Assalamu alaikum. My name is Dr. Amber Arshad, and today my topic of presentation is toxoplasmosis. Bismillahirrahmanirrahim. Sometimes we are tested not to show our weaknesses, but to discover our strengths. The learning outlines of my presentation are introduction, epidemiological factors, chain of transmission, clinical manifestations, level of prevention, and recent advances. At the end of the presentations, student will be able to describe the epidemiological aspects of toxoplasmosis, preventive aspects of toxoplasmosis, national and global updates, and the recent advances. I will give a brief introduction of human toxoplasmosis. It is a zoonotic disease caused by an obligate parasite Toxoplasma gonadie. It infects a wide range of animals and birds, but apparently there is no clinic. There does not appears to cause any disease in them, or shows any signs and symptoms of the disease. Toxoplasmosis is actually a disease of blood and lymphatic system. Cats are the critical part of the life cycle. It is usually acquired in humans by eating undercooked meat, but can also be acquired by contact with cat feces. The primary problem of toxoplasmosis infection is a congenital infection of fetus, resulting in either stillbirths or a child with severe brain damage or vision problems. Toxoplasmosis is a part of the well-known congenital infections named as TORCH infections that includes toxoplasmosis, Treponema pallidum, rubella, cytomegalovirus, herpes simplex, hepatitis virus, HIV, and varicella and parvo B19 virus. Recently, Zika virus has been considered by WHO as an emerging torch agent that may seriously threaten public health. Now, the problem statement. Toxoplasmosis is most common in areas with, where the weather is warm and moist, normally present in 50% of the population of Central and Southern Europe, Africa, South America, and some parts of Asia. France, in France, this disease is very common because of the preference of minimally cooked and raw meat. In Sweden, 20% of the population shows the toxoplasmosis infection. And according to the Center of Disease Control and Prevention, in US, almost 60 million children, women, and men are infected with this protozoa. The global annual incidence of congenital toxoplasmosis was estimated to be 190,000 cases, and the burden is high in South America and Middle East and low income countries. However, in Pakistan, although toxoplasmosis is found in most parts of the world, but in Pakistan, the cases of this disease are relatively low. The prevalence of Toxoplasmosis gonadie infections in Pakistan have been reported in young children, in pregnant women, and some high-risk groups with comorbidities, but no reports on toxoplasmosis in food animals exist. According to one paper, the screenshot I've shared, the overall prevalence of Toxoplasma gonadie was 29%. Among the age groups, highest prevalence was reported among age groups 1 to 10 years and lowest among 61 to 70 years in Pakistan. The risk factors identified were the presence of cats in the vicinity, extensive management systems, poor hygienic conditions, and this information is important as it can serve as a roadmap for building control strategies to minimize the risk of this zoonotic disease in farm animals and humans. Now, the epidemiological factors that includes host, agent, and environment. Toxoplasma gonadie is a protozoan parasite that infects most species of warm-blooded animals including humans, and causes the disease toxoplasmosis. The incidence of infection increases with age, and several studies have shown higher prevalence among women at childbearing age, although children are more exposed to the source of transmission of this parasite. No gender differences are found, and some studies have been done on animals that shows significant differences, but not in humans. The female mice had higher prevalence of Toxoplasma gondii antibodies than males, but these studies have not been reported in humans. Immunity is acquired in women, in particularly protective to fetus. Immunosuppressed and AIDS patients have changes in their host resistance and can present and the infection can present as fulminating acute toxoplasmosis. Um, Non-seasonal worldwide distribution, but the rainy season is the can usually shows higher incidence of cases. Usually the seasonal precipitations affects the river flow that can deliver the oocytes from the land to the water and can increase the incidence of waterborne, also the coastal contaminations. And but most natural infections acquired in humans is through ingested uncooked meat that contains the oocyst of the infected with protozoa, or the food contaminated with cat's feces. The incubation period is ranges from 10 to 23 days after the ingestion of undercooked meat and from 5 to 20 days after ingestion of oocysts from the cat's feces. Toxoplasmosis is not passed from person to person, except in the instance of vertical transmission, in which the protozoa is transmitted from mother to child or fetus. People typically become infected by three principal routes of transmission: foodborne, animal to human zoonotic, and mother to child congenital transmissions. Now, a brief description of the pathogenesis. It's an obligate intracellular parasite. Definite host is cat, intermediate host human. Uh, Proliferative form is tacozytes, and modes of transmissions I've already mentioned are undercooked meat and the contamination with cat litter and transplacental transfer. This is a brief life cycle that starts with the definitive host cat, and the oocyst produce sexual completes its sexual state inside the cat. Then it the oocyst pass through the feces either to the intermediate host, or and it can be transmitted to humans in three ways. Either these cysts the through the food, undercooked food that contains the cyst, or through an intermediate host, or the humans come in direct contact with food and water contaminated with the oocyst. And later, if the pregnant females are infected, then they can transfer it through tacozytes to the infected to the fetus, and it can cause congenital infections. This is how the protozoa transfers from the definitive hosts to the intermediate host. In this slide, it's a rat. It's like the rat's brain, and then the cats again consumes that rat's brains and get infected. So it's a vicious cycle that continues. Now the clinical features. The disease, normally the person who have not been previously exposed to this protozoa, and they are termed here as healthy people, and I am excluding here pregnant women. Now, in healthy people who become infected with Toxoplasma gondii often do not have symptoms because their immune system usually keeps the parasite from causing illness. But mild flu-like symptoms can appear that can last for weeks to months, and then they go away. However, the parasite remains in person's body in an inactive state, and this can be reactivated if the person becomes immunocompromised. Now, If a female of a childbearing age is infected, or a mother, this mother to child or congenital transmission occurs. Generally, if a woman has been infected before becoming pregnant, the unborn child will be protected because the mother has developed immunity. But in other case, if a woman becomes newly infected with toxoplasmosis during or just before pregnancy, she can pass the infection to the unborn baby. That can result in miscarriages, stillborn child, and child born with signs of congenital toxoplasmosis. An infant infected before birth often shows no symptoms at birth, but may develop them later in life with potential vision loss, mental disability, and seizures. Now, the perinatal infections can cause impaired growth, developmental abnormalities, and mortality. In utero infections, mainly the causative agents are the torch, toxoplasmosis, syphilis, rubella, cytomegaloherpes, and intrapartum infections are mostly caused by group B streptococcus, hepatitis B virus, and HIV. Now, if a pregnant woman is infected, then it may result in abortion, an overt disease of the fetus that may show symptoms, and this is known as the classical triad of congenital toxoplasmosis, including hydrocephalus, intracranial calcifications, and chorioretinitis. In case of subclinical infections, no symptoms are present at birth in the fetus or in the infant or the baby. Late onset symptoms include mostly the eye symptoms, chorioretinitis, or there may be no symptoms at all. In the here are other graphical description of the symptoms of intracranial calcifications that are diffuse, hydrocephalus, and there are blueberry muffin rash. Long-term CNS complications include intellectual disabilities, seizures, palsies, and vision impairments. Usually, the drugs that can be given in this case are pyrimethamines, sulfadiazines, and leucovorin. Persons with ocular disease. Eye lesions from congenital infections are often not identified at birth but occur in 20 to 80% of congenitally infected persons by adulthood. However, in US, less than 2% of persons infected after birth develops eye lesions. Eye infections lead to an acute inflammatory lesion of retina, which cause scarring and can eventually lead to blindness. The most common symptoms of this ocular disease include eye pain, photophobia, tearing of the eyes, blurred vision, and it may cause blindness if the damage is extensive. Now, what happens if the person with compromised immune systems come in contact with this protozoa? Persons who have acquired HIV infections and were not infected previously with toxoplasma are more likely to develop a severe primary infection. In second case, the persons who were infected with toxoplasma at some point before they become immunocompromised are at a risk for developing a relapse or reactivation of toxoplasmosis with fever, confusion, headaches, seizures, and poor coordination. Toxoplasma infection can reactivate in immunocompromised pregnant women as well, who were infected with toxoplasma before their pregnancy. This leads to the congenital infections. Now, the levels of preventions. Primary prevention include health promotion and specific protection. Now, how to control and prevent toxoplasmosis and to control and prevent its transmission in the community. Avoid the human contact with cat feces is highly important. Changing of cat litter and safe disposal can prevent transmission, and pregnant women should avoid contact with kittens. To reduce the risk from death temperatures, avoid safe temperatures. Color is not a reliable indicator that meat has been cooked to a temperature high enough to kill the harmful pathogen, and do not sample the meat until it is cooked. Wear gloves while gardening, fully cook the meat, and wash fruits and vegetables thoroughly. How to reduce the risk from environment? It's by taking general hygiene measures, avoid drinking untreated water, wear gloves when gardening and during any contact with soil and sand, teach children the importance of washing of hands, ensure that the cat litter box is changed daily, and the toxoplasma parasite do not become infectious until 1 to 5 days after it sheds in the cat feces. And the picture also represents the same things I've already mentioned. Now, if you are pregnant and immunocompromised, what things should be done? Avoid changing cat litter if possible, and wash your hands with soap and water thoroughly if no one is there to do the job. Keep cats indoors to prevent them from hunting and reduce the chance they will become infected. And do not adopt or handle stray cats, especially kittens, while you are pregnant. Now, a little about the vaccine. Currently, there is only one live vaccine available. That is, brand name is Toxovax, and it contains S48 strain and has been licensed to use to avoid congenital infections in sheep, but it's only available in UK, Ireland, France, and New Zealand. However, this vaccine is expensive and cause adverse effects. And the vaccine may revert to a pathogenic strain, so it's not suitable for human use, and there is currently no licensed vaccine available for humans. A One Health approach is proposed for the development of vaccine. A killed vaccine is preferred for the humans. The targets for the toxoplasma vaccine is to prevent and reduce the disease that reduces the transplacental transmissions of tococytes, bradiocytes tissues in food animals, and cat sheds oocytes in feces in the environment. But in humans, according to this One Health approach, a vaccination program is required that includes a killed vaccine so that we can prevent the cases in the countries where the number of the incidence is really high, and the incidence of congenital infections is also high. This is the screenshot of this program. Regarding the human vaccine, the major target for the human vaccine would be to prevent severe consequences of congenital toxoplasmosis in pregnant women. And the reason for this would be to try and induce protective immunity to T-gonady young women prior to them becoming pregnant, and therefore reducing the risk of Toxoplasma gondii. But this vaccine is recommended for all ages if it comes in market and is licensed. Then it would be preferred for all ages, not only targeting the women of young age or the women in reproductive age. Now, the secondary prevention. It includes early diagnosis and prompt treatment. So, the specimens that are desired for the diagnosis of toxoplasmosis include blood, sputum, exudates, lymph nodes, striated muscles, biopsies, and ventricular fluids. Normally, toxoplasmosis is diagnosed on microscopic examination of tissues, smears and sections stained with Giemsa stains, periodic acid skip methods. The densely packed cysts can be seen in brain and other parts, suggest chronic infections. Another method for diagnosis of toxoplasmosis infection is through the serological test, that is Sabin-Feldman dye test, based on the principle of antibodies to toxoplasma, that normally appears within 2 to 3 weeks, but some changes occurs due to this in the protein coat of this protozoa, and it does not get stained, and the unstained organisms gives the presence of serum with antibodies. Screening of pregnant women is really important. Periodic screening of pregnant women with high risk of IgM antibodies is recommended. Care of meat: avoid raw and undercooked meat. Freezing temperature should be -20, and heating should be at 50 degrees for 4 to 6 minutes to sterilize and destroy the cysts. The newer methods of diagnosis include immunofluorescent assays, ELISA for IgG, IgM, PCRs, and Franklin intracutaneous tests that are usually used for research purposes for in a large population in population. Now, the combination of pyrimethamine, sulfadiazines, and trisulfapyrimidines are used as a combination for treatment of this infection. Alternative drugs are spiramycin, clindamycin, and in pregnancy, spiramycin is recommended drug. Along with the treatments, systematic education and serological screening of pregnant women are the most reliable and currently available strategies for prevention. Now, the recent advances. This paper, here is a systematic review showing the global burden of the congenital toxoplasmosis. As mentioned earlier, the global annual incidence of congenital toxoplasmosis was estimated to be 190,000 cases, and high burden was seen in South America, in some Middle Eastern and low-income countries. Nowadays, toxoplasmosis is being considered as a neglected parasitic infection that also includes Chagas disease, cysticercosis that may cause severe illness. The limited resources have been devoted to better understanding their burden, their impact and burden. Actually, this is a neglected disease. More and more research is needed to evaluate the risk factors, to evaluate the treatment options, to evaluate the diagnostic factors, so that these diseases also comes in consideration and the mortality and the congenital deaths can be reduced. Childhood parasitic infections are endemic, especially in United States. And these infections are also found in southern states of Africa, in America, and the populations with lower socioeconomic status. Approximately 300,000 people in United States have Trypanosoma cruzi infections, and these parasitic infections are endemic in United States, are not uncommon but are understudied. Antibody prevalence and risk factors of Toxoplasma gondii infection in women from Multan. The studies shows that the overall prevalence of these antibodies was 17.6%. Antibodies to Toxoplasma gondii were presented in 19.4% pregnant women and 15 of the samples from 171 non-pregnant women. This study identified miscarriages history, pet ownership, type of residence, marital status, source of drinking water, eating habits as significant risk factors associated with presence of antibodies to Toxoplasmosis gondii infection in Pakistan. The epidemiology of toxoplasmosis shows that 17.4% apparently healthy school children in the age of 13 to 20 years were positive for the antibodies, and the present study shows simply how prevalence of shows the prevalence of toxoplasmosis antibodies present mostly in the adolescent group. This study is related to the birds, and the birds acts as an intermediate host, and according to the study 25% individual birds species were seropositive, and the study provides evidence of toxogonida antibodies in wild birds of Pakistan. This graph is taken from another study, the seroprevalence of Toxoplasma gondii in cattle, showing that most of the cases of toxoplasmosis among cattle were in the rainy seasons. The peak is of the rainy season. Other is the relative humidity, and the third line is for the maximum temperature. So rainfall is directly related to the incidence of this infection, and that resulted in animal abortion in Punjab province of Pakistan. These are the references, and now it's time for the MCQs. Now, MCQ number 1 is yes, because Toxoplasmosis cat is the definitive host for this infection. Now, which statement regarding Toxoplasmosis is correct? A pregnant woman who has acquired Toxoplasma any time before pregnancy is likely to deliver infected infant. Women who develops to toxoplasmosis during one pregnancy is more likely than other women who give birth to an infected child in a subsequent pregnancy. A woman who acquires toxoplasmosis during last trimester, a woman who acquires toxoplasmosis during last trimester is more likely to deliver infected infant than she would be if she acquires infection during first trimester. And last is toxoplasmosis in a person with Hodgkin disease probably is due to a newly acquired infection. No,
A.
the answer no, the answer is C because if a pregnant woman acquires infection during the first trimester, it mostly results in abortions and stillbirths. And the infections acquired in the last trimesters, they are more likely to deliver the infected infant that on times of birth might not have any symptoms, but later on can present with severe symptoms of congenital toxoplasmosis. Sabine Feldman dye test is used to demonstrate infection of yes.
B. B.
It's the standardized logical test. What is the incubation period for toxoplasmosis? Exactly, 5 to 20 days. D is the answer. Now, fifth MCQ. A 24-year-old primary Paris woman in her 8th month of gestation develops a positive IgM titer to Toxoplasma gondii for the first time. She should be advised by her physician that major organ damage can be reversed by prompt treatment. Retinochoroiditis can be prevented by drug treatment of infant with positive IgM. A newborn with positive anti-toxoplasma.
B.
No, the answer is B because retinochoroiditis is the complication that appears in the later age and can be prevented if prompt treatment is given to an infant with positive IgM response. Now, six is which of the following is the commonest infection cause
B.
of blindness? Yes, because of the toxoplasmosis infection, it causes scarring and retinal damages in the later ages. Toxoplasmosis in the fetus can be test confirmed by a IgM antibody against toxoplasma in mother, IgM antibodies against toxoplasma in fetus, IgG antibodies against toxoplasma or IgG in fetus.
B.
Right, the answer is B because the only antibody that is produced by the fetus is IgM antibodies. Why cats are considered as a definitive host for toxoplasmosis?
B. B.
Yes, because it is a definitive host and the sexual cycle of toxoplasmosis is only completed in the definitive host that are the cats. 30-year-old veterinarian visits her obstetrician for the first trimester prenatal checkup. She has no complaints. Routine physical examination may be done only for mild to symptoms. She is prescribed pyramicin, but she is non-compliant. Her baby is born with hydrocephalus and cerebral
C.
calcification. Yes,
C.
because she was non-compliant and the drug of choice was pyramicin, and she could have avoided these congenital malformations. But since she was non-compliant, so her baby was born with these malformations, anomalies. And last is which of the following is most common routes of exposure to toxoplasmosis? I am
B.
referring to human. Yes, expression to undercooked and contaminated meat. This is the key, and thank you.
Thank you very much, Dr. Amber. It is a wonderful presentation as always. The most important part that I want to emphasize is your MCQs. You have brilliantly presented the MCQs and how you have given the correct answer. It is something that I want to follow in future too. All the presenters must give the correct answers of MCQs as it has today been presented without having any doubt in mind. So thank you very much, Dr.
Thank
Amber.
you, ma'am.
Toxoplasmosis is a very important topic, and we always divide it into two important type of people: one with the normal immune system, and other with compromised immune system. So all those who have normal immune system, 90% of them remain asymptomatic. The main challenging situation is when the people are immunocompromised. What happened after toxoplasmosis initial infection? Usually, the toxoplasmosis infection later on goes to cyst phase and it remains dormant for years and years in anybody. So then, especially when the people have their immune defenses weakened, either because of AIDS, cancer, immunosuppressant medication, or due to pregnancy, then this infection spreads out of control and it becomes deadly. The dormant toxoplasmosis infection, when it suddenly become active, it can cause severe brain infection. And what can lead to it is encephalitis, seizures, neurological infection. And what happened if the newborns are infected? Actually, the newborns, when they are infected by it, we are always looking for two important things. One is in their eyes, and other is in their developmental disability. So, as we know, the eyes are the windows of the brain. So, eyes and brain, if they are infected, it is something that has a very bad prognosis. Newborns with congenital toxoplasmosis are treated for at least 1 year. The pregnant women who develops toxoplasmosis, her child's risk of congenital toxoplasmosis, it decreases by 60% if she is treated with prophylactically medication so that the baby would not get congenital toxoplasmosis. So another point in prevention is that the pregnant women, they should be offered treatment to congenital decrease the risk of congenital toxoplasmosis by 60%. Another recent advances is about anti-malarial agents. Dr. Appar has wonderfully described many different pharmaceutical agents. However, the recent advances is about anti-malarial agents. Why we are very much concerned as a public health physician with anti-malarial agents and anti-toxoplasmosis, because we know that both of these are parasitic diseases, and these parasite borne infections, they are causing high burden globally. So if we have a treatment that can bridge between two distant illnesses and can help in eradication and control, it would be decreasing the global burden. My question from the audience is, what are the other strategies to control and eradicate toxoplasmosis? Dr. Amber, would you please let us know what are the strategies to control and eradicate toxoplasmosis from this earth?
Ma'am, we can control this disease in two ways. There is environmental control, and which includes the control of the stray cats that are the cause. We can either educate people, we can introduce a vaccine for animals as well as humans, and we can also, ma'am, I know these points, not nothing else.
Okay, thank you very much, Amber. Would you please elaborate about vaccination, because this is something that I am really surprised to know about it.
Ma'am,
Can you
currently,
elaborate about it?
a live vaccine is available, S40, containing the S48 strain of this toxoplasma, available in New Zealand and various countries, where it is being given to sheeps and related animals, but not in cats. And some experiments have been done. They have shown good results, but still there is a debate of how it will react in humans, because it is a live vaccine, and some study results have shown adverse clinical diseases, development of adverse clinical diseases in the study animals. So this cannot be given to humans. One Health approach is being developed, so that a program is developed for toxoplasmosis, a vaccination, that and a kill vaccine should be used in that, so that the vaccine induced disease is the chances of vaccine induced disease are minimum among humans. But still these are under study, the development of vaccine.
Thank you very much, Amber. S48 vaccine, as you have said, it has been animals, and there is a lot of debate that is going on. It is only used in well developed countries, and I'm really happy as well as I'm surprised that you have talked about something that is